I have a passion for what I do, and I chose this profession for a reason. And that reason was I want to drastically impact people's lives. And I feel like I do that on a daily basis.
We are live, eShadowing with Dr. Ricky Brown. How you doing, my friend?
Good. How are you doing? Bobblehead's with us.
Got your own bobblehead.
I saw episode 1. He had one. I'm like, dude, I have one of those. I got to bring him in.
Bobblehead Brown. That's the name. That's awesome. Do you have your skull? Is your skull named?
It's not. I should, but it's not. My cadaver was named Grace.
Grace? Yeah.
Yeah, we named her Grace.
That's interesting. Yeah. At our school, they said don't name your cadavers.
Humanizes it too much.
Yeah, I think so. I don't know. Like they had their names. Don't give them meta names. It was interesting.
Yeah, I mean, you know.
Anyway, I'm excited to be here with you. We got 1,300 people live already. Just ticking up. Thank you for being flexible and showing up here last minute. I hope Dr. Coots a very quick recovery from his COVID illness. I think he's doing well. He's at home. He's just hacking up along. He's like, I can do it, but I might be coughing every 2 words. So
in a mask.
But I messaged you and you came to the rescue. So I don't care what they say about Georgia Bulldogs. I have nothing but respect for you. So
you knew he had to get that in.
Knew I had to get it in. So let's talk plastic surgery, Dr. Brown.
Let's do it.
We got lots of people here ripping and raring. Ask your questions as you want. We're going to have a little presentation. We'll have some case studies. I know you all love it. So plastic surgery. Why plastic surgery?
You know, for me, so for those people that don't know me, a lot of you might not have heard your other podcasts. I'm double boarded in general surgery and plastic surgery. So when I was in general surgery, I just wasn't sure what I really wanted to do. I knew that I wanted to be a surgeon. And I think what grabbed me about plastic surgery is I did a lot of heavy trauma and got to see some reconstructive work and had some friends that were in plastics. And I think what drew me to it was the diversity of the field. You could operate on young kids, babies, cleft palates, cleft lips, to older adults, to middle-aged women, men, everything. Kind of like the idea of mastering a ton of different types of procedures and finding my niche within that specialty.
Talk about the kind of bad stereotype that plastic surgeons get, or plastic surgery in general gets, where when you go to anyone and see plastic surgery, the first thing that pops into mind for everyone is nose jobs, boob jobs, all these BBLs, all these things that are cosmetic in nature. But plastic surgery is so much more impactful to people's lives than just cosmetic. Talk about kind of the breadth of the field of plastic surgery.
Yeah, it's funny. You literally took a slide out of my presentation. And what I was going to talk about when we did was exactly this, is that first of all, I had a rhinoplasty when I was 24, so I want to preface it with that, because I think what's important for people to understand is all they see the Hollywood, botched, all the Kim Kardashian, all that stuff. That's what everyone else sees. What they don't see is the reconstructive world that we go through with cleft palate, cleft lips, breast cancer reconstruction, microvascular reconstruction for jaw cancers. There's so many different things that we do in reconstructive surgery that's so unbelievably important. But to me, equally as important is some of the cosmetic stuff. And I think that what people fail to understand is that why does anyone make change to their body? Why does someone get a tattoo? Because they want to look a different way and it makes them feel a certain way. So if a person's like, if a person is desiring some physical change that they can't do otherwise with meal planning or exercising, when I do and plastic surgeons do things for them to make them feel better in their skin, we're treating the mind, which translate to their relationships, to their job place, and just the way that they carry themselves. So I think that whether it's reconstructive or cosmetic, there are positives, but most people, like you said, they just see the Hollywood amped up, commercialized, bad side.
Yeah. Well, awesome. I don't want to steal too much from your presentation. I think maybe we should just jump right into the presentation, and I'll be watching the chat and I'll interrupt you with questions and we'll just go from there.
All right, please do. So Ricky Brown, plastic and reconstructive surgery. I live in Scottsdale, Arizona. My goal with this presentation, guys, is I just want to teach you a little bit about what I do, how I got here, where it came from. My goal in this presentation is not just to kind of hammer through a ton of cases and talk about plastic surgery. I feel like my job is also as why Dr. Gray has me here, is being a mentor to help motivate you guys, tell you a little bit about my story so that hopefully that helps resonate with you if you have similar stories as me, and then you can end up getting where you want to be. So I want to talk a little bit about, and my wife is on here, so she's watching, but this is my wife, Alexis Brown. And we met when I was in general surgery training, and she is my rock. She's amazing. She's an incredible partner, an incredible mother. She's formerly a dental hygienist and started another company about a year or so ago, and then decided to start this overnight oats company during COVID, which is doing great. So she is an amazing person, and she's watching right now with my twin boys, Brody and Graham. So the middle picture is from the other night. We had a whoopee cushion and we had a police officer, and then they do some jujitsu, not right now. But these boys are amazing. They're 11 years old. They're identical twins. They look a little bit different to us, but they're amazing. And I know they're watching. Brody, Graham, give a shout out to you guys. I love you kids so much. A little bit about my roots. So I grew up in the South. I am from Macon, Georgia. Deep South. And we moved to Atlanta when I was about 12. And you can just see growing up, I doing my hair, doing some fishing, and eating some Nilla wafers, baby. Life couldn't be any better. But I had an incredible upbringing. I have two sisters. My parents still live in Atlanta, and they're awesome. My dad just turned 89.
Can I tell you, before you rip the gators, Nilla wafers are one of the most underrated cookies out there.
With peanut butter, by the way.
Oh, so good.
So good. I'm not going to rip the gators. So as you guys all know, I am a Georgia Bulldog. So when we moved to Atlanta, I ended up going to Syracuse for a couple of years, and I transferred to the University of Georgia. Dr. Gray and I, we wouldn't argue that the SEC is the greatest football conference in the Southeast in the league. Of course, I'm a Georgia Bulldog, and he's a lonely little Gator, along with my mom, who we're squaring up next week. So everyone tune in, and we're gonna watch Georgia crush the Gators next Saturday. But no,
we should have a friendly little wager of what we'll have to do on like TikTok or something, or Instagram story if the other team wins.
We should. Maybe we'll have to have the students write in what they want us to do, what the wager should be. That could be dangerous.
I like it.
But anyway, so if for those of you guys you don't know, we meet up in Jacksonville every year, and it's always a great time. And so me and Dr. Gray are going to have to do that one year. All right, this is a great slide. Here's the reason I pulled this slide up is because I wanted to talk to you guys a little bit about social media and the world that we live in now, because all of you guys are in a different world than we were in growing up. I didn't have social media. And so I think what's really important for you guys to understand is that we all look around at everyone around us. I still look at other surgeons in town and I think to myself, man, could I ever have a practice like that person? And so you probably look at us and go, I could never get into med school, or you start comparing yourself. And I think what you guys don't realize is all you see is what's above the water. You see the success, that's all you see. What you don't see below the water is everything that Dr. Gray and I have been through, and the things that you're going through are the persistence and the failure and the sacrifice and the disappointment and the getting back up and the continuing to go. So this is the part of the talk where I wanted to tell you guys that don't get frustrated, because we all fail. I don't know anyone on planet Earth who doesn't fail. To me, what defines you is what you do after you fail. How are you going to proceed when you fail? So I love this slide, and I think you guys should snapshot this and keep it and look at it every now and then to remind yourself that all you're seeing on social media is the most perfect world. You're not seeing everything that goes on behind the scenes.
A lot of people like to blame social media for that. I'm like, there was nothing different in the 50s when you would walk out after having a rough night, arguing with your husband, with your wife, and you walk out and you see your neighbors. How's life? Oh, everything's great. Like you're just demolished inside. Like we as humans just love putting our facade on. So it's crazy. I want to say something, because there was something that we took a quote from the podcast that we did, and I wanted to mention that premedyears.com/411, you came on and talked a little bit about your journey. One of the quotes was like, you have to fail. And people were like, oh, I don't agree with that. Like, you shouldn't have to. Like, well, no, you don't literally have to fail. It's not like you're saying go out and get arrested for possession just so you can have something that you can crawl up from. but I think it's important to learn from your failures is really a lot of what you talk about. So
yeah, 100%. I mean, I feel like, we always talk about hard times, and look, COVID's the same thing, right? I mean, this is when we grow. We grow when we're in these uncomfortable situations. And when we fail, we grow to figure out how to be successful the next time. And to me, I think failing, it characterizes you, it shapes you, it carves you, and it makes you become who you are eventually later in life. So let's jump into my practice. So this is my crew. So I'm in private practice, guys, in Scottsdale, Arizona. I'm the only guy in the practice. We have some plans for growth, which I'll talk about. Some of these people actually in this picture aren't with us anymore, but I love them all. They've moved on, but most of them are. So I have an office manager, Missy, starting from the right, my office manager, Octavia, then Missy, a medical assistant, who she's not here anymore, but we have a new one. That little redhead poking over my shoulder there is my sister, Laurie. Katie in the background used to be front office, and then that's my nurse, Skylar, who does all of our nurse injecting. So let's talk a little bit about plastic surgery and what is it. Now, I know you guys in week one, if you're here, you heard the other hand surgeon talk about plastic surgery. So we're going to overlap a little bit. But people always ask me, where did the word plastic surgery come from? And it always makes me laugh because it really is a good question. But the answer is plastikos is the Greek term for to shape or to mold. And so what I put up here was a bar of soap that was carved into a boat. And what's funny about this is I want to say the Medical College of Georgia makes them carve soap at their interview for plastic surgery, which is really interesting. But that's what plastic surgery means. It means to mold or to shape. And so it makes sense that that's what we are.
I'm pretty sure those old school, like, sew a piece of cheese together, like they used to do that kind of stuff. I'm pretty sure those have gone out of the window with laws and stuff.
I would love to have been around at that time just to watch people sweat, because Lord knows I was on the other side of it and it was not fun. All right, so Dr. Gray and I, we've talked about this before. We talked about it in the podcast, and I think this is really, really important. I want to talk to you guys about what defines you. This is one of my early TikToks. I'm going to see if this works. It's real quick. So the reason I wanted to show you this slide is because this told my story. And so what I want you guys to realize is that you have to tell your story. Your story is different than my story. How did I get into medical school? It's a long story that we would have to discuss in another day, but you can listen to the podcast. But the purpose here is to show you guys that this is my story. This is my journey. I was a senior in college when I decided to become a doctor. And so stay in your lane. Tell your story, but what's the most important thing is you're authentic about your story. You have to be authentic and just be you, because people will feel that. You want to know how to differentiate yourself. That's how you differentiate yourself along this process. Yes, you have to make good grades. You've got to do all that stuff. Everyone is trying to get a good MCAT score, and you have to make good grades. But I think then what differentiates you is what your story is. So start to think about what your story in life is and what shapes you, so that you can believe in yourself. And like I said before, you have to be willing to fail. So that's that. All right, so let's talk about board certifications. What do I have? So I'm double board certified by the American Board of Plastic Surgery, #1. But first, I did a full general surgery residency. So I did 5 years of general surgery. So I'm board certified by the American College of Surgeons. And I did a year of research in between in scarring and wound healing at Northwestern. I trained in Chicago. I went to the Chicago Medical School. I am a fellow of the American College of Surgeons, and I am a member of the Aesthetic Society and the American Society of Plastic Surgery. This picture is me. And so for each of my boards, I had to do 2 sets of boards. I did written boards and oral boards for general surgery, and I did written boards and oral boards for plastic surgery. What you're looking at is me holding my iPhone before I walked down to sit into that chair for my last set of boards ever. That was right before I had to walk into a room and start getting grilled about plastic surgery. So this is my oral board exam, and that was what it looked like when I was standing in that hallway, actually here in Arizona. So pretty crazy day.
A lot of students think this getting into medical school is like the tip of the mountain, like the very top, like no more tests, no more being challenged. I took my MCAT, I got into medical school, and then you're like, oh crap, there's more tests. And then you finish medical school, like, all right, I'm a doctor, I'm done with tests, I don't need to study anymore. And then it's like, oh crap, I have my boards I need to study for. It just never ends, huh?
It never ends. I just got an email 2 days ago that I need to take my test to recertify for general surgery. Actually, I recertified for general surgery already, and now I participate in the annual. They made it so you could take a little test every year instead of a big test every 10 years, but it never ends. So just get used to it. But it gets a lot easier. All right, so those are my certifications. So we already talked about this, so I'm going to kind of just bust through this slide. I was going to talk about exactly what Dr. Gray asked at the top of the show, and that was just the stigma of plastic surgery and how reconstructive and cosmetic, there are good things that come out of both of those. I will tell you on social media a lot, and I used to get this on TikTok a lot in the beginning, is people would say, I would never change anything about myself. And that's great if you wouldn't, but don't be mad at someone else who might want to change something to make themselves feel better. We're not talking about the crazy stuff you see in Hollywood. So that was the slide that I had put up for that. And this is real. So I get this. So we get people that come in and have obscene requests about what they want to be like. And the reason I put this slide up is that I turn people away. I don't operate on everybody. I'm ethical. I only do what I think is right. And so when you guys move forward into your specialties, make sure that it's not all about the money. It's about doing the right thing for people. And I kind of pride myself on that. And so this slide just cracked me up because he just nails the picture on her face. And he's like, there you go.
There you go.
You're done.
Yeah, it'll be interesting to see with technology, with AR and VR technologies in the future to like be able to tell everyone else's AR devices, be like, this is how I want to look to you. I'm like, oh, that'd be really cool.
It would be cool. We kind of do that. We have that for breasts. It's called Vector, where you can kind of simulate what they'll look like with implants or surgery. But I don't like it because I think it causes a false sense of what they want when they don't get that exactly, and they still got a good result. Then they don't perceive it as a success. All right, so let's talk real quick about how do you become a plastic surgeon. I'm just assuming you guys have gotten into med school. You've been through all that. Dr. Gray has helped you get there. Let's talk about once you're there, what is the process to become a plastic surgeon? So there are two routes that you can go. The first track that you can embark on is an integrated program where you get in right out of med school. And you basically do a 6-year program where the first 3 years are focused more on the general surgery types of rotations. So you'll do orthopedic surgery, vascular surgery, all of those types of things. And then the second 3 years are usually more heavily focused on plastic surgery. The difference, though, is that you do get more plastic surgery in your first 3 years than you did the old way. And the old way is kind of the way that I did it. And that track number 2 is you could do I put some surgery residency. And the reason that I said that is because my co-resident was an orthopedic surgery trained guy. I don't think it matters. As long as you do a surgical residency, he decided part of the way through that plastic surgery was what he wanted to do. And after he finished that residency, he then applied to do additional time, which is an additional residency for plastic surgery. Now, when I went through, it was only an additional 2 years. Now it's changed and it's a 3-year track. So it doesn't matter whether you do the integrated or you do a surgery specialty, you still have to do 3 more years for plastic surgery. So the integrated is probably the fastest track, but when you do it old school like I did, it's the realest path. I'm just kidding. It's either way works. I just did it the long way. I was in the middle of general surgery thinking to myself, man, I've only got like 2 years left. I'm just going to finish this off because I've worked so hard to get here. And to be honest with you, for me, I learned so much from doing trauma surgery, the heavy trauma surgery and the critical care stuff, that if I got pulled into the ICU, I might have had to brush up a little bit, but I could have gone and run vents and drips and done all that stuff. And I couldn't have done that from an integrated program. I don't think that's necessary, but that's just my track. I'm glad that I went the way I did, but the other way is a little bit shorter. But either way doesn't matter. You'll be well trained.
Do you think there's a benefit to doing track 1 where you get a lot of this extra training, maybe extra kind of thinking through different diagnoses, different issues versus going into plastics directly?
I don't think you mean track 1
track
versus
2.
Track
I mean,
2.
yeah. Is there a benefit to doing track 2? Yeah.
Look, I think today that the integrated program has been around for so long now that they've made all the adjustments to give them the same kind of exposure. It's hard for me to say it because I haven't been through it, but some of my friends who have been through that track, they're great surgeons. But for me, because I didn't know what I wanted to do, I'm glad that I got all of the critical care training and the trauma training that I did, because it made me, I don't want to say fearless in the operating room, but it made me under pressure situations not scared. Like I'm calm in the OR. I
Yeah.
know how to handle things because I've seen, and I don't know that you get that in track one. You do a little bit, but I was in a knife and gun club program in Chicago, and we were just cracking chests all night and putting chest tubes in and central lines. So it was just, for me, it was the way. But I don't know that there's a benefit. But for me, I was happy to go that way.
Yeah. Rachel asked a question about the having some quote unquote some surgery residencies. She just asked about what about ENT, and I definitely know some friends who are ENT trained plastic surgeons. Facial plastic surgery is typically what they go into. Even oculoplastics for ophthalmology people going into some plastics as well.
Or full on. So I trained in Nebraska for plastic surgery at the University of Nebraska Medical Center. My program director was ENT and then did plastics. So he did a full plastics training. So he wasn't just facial, he did everything. One of the new attendings there, who's now the program director, was dental school, general surgery, OMFS, craniofacial at Stanford. I mean, dude, he was the nicest guy and literally the most talented surgeon that I've ever operated with in my life. He made everything look so effortless. Not that we struggled, but how you see like an athlete on the field and you're like, they just move different. He was that way. But yeah, no, you can do any specialty and still do plastic surgery. But what Dr. Gray said is correct. Sometimes people will do ENT and then go do an extra cosmetic fellowship in facial. And I'm going to talk about that because I think that's okay. But I'm going to talk about the other ways where people get duped about plastic surgery that I think you have to be careful about.
Okay.
So the American Board of Medical Specialties is the biggest governing institution in the United States that basically says, you guys can certify pediatricians, you guys can certify plastic surgeons, you guys can certify internal medicine. So the American Board of Medical Specialties is the big grand poobah that decides which boards get to actually certify us. The reason I'm mentioning that is for what I just saw, which was a good segue, was that the American Board of Plastic Surgery is the only institution in the United States that is recognized by the American Board of Medical Specialties. So if a surgeon says that they trained in the American Board of Cosmetic Surgery, which we see today, people put on their website, I'm a cosmetic surgeon. I trained at the American Board of Cosmetic Surgery, not recognized by the American Board of Medical Specialties. The American Academy of Cosmetic Surgery, not recognized by the American Board of Medical Specialties. Now, that's not to say that those people aren't good surgeons, but I'm just telling you that you have to be careful that some people think those people are plastic surgeons. And so I like to make this comment. All plastic surgeons are cosmetic surgeons. Not all cosmetic surgeons are plastic surgeons. So the people in that middle track there, they didn't do all the reconstructive stuff that we did. I don't know anything about how they trained for cosmetics. And while they might be good surgeons, you have to be very careful about who you choose and make sure that they're board certified. And I think board certification is very important. And I always mention this too. The way I say it is that, does that mean that every board certified plastic surgeon is a good surgeon? No, everyone on the street should have a driver's license and they drive, but not everyone's a good driver. So it's up to the patient to determine, are they a good board certified plastic surgeon or not a good one, because those exist as well. All right, so what do? We do a variety of non-surgical, reconstructive, and cosmetic things. In my office, I have a nurse injector who is fully trained in doing Botox and filler and peels and all that stuff. My time is better served doing surgery. I used to do all of my own injecting, but now she does it all. Then there's the cosmetic and the reconstructive track. And the cosmetic and the reconstructive track, to be honest, I listed things here, guys, but it's head to toe, everything. Breast cancer, skin cancer, orthopedic surgeons have hip blowouts or infections from hip replacements that we need to help them reconstruct. Pediatric surgery, cleft palates, cleft lips, craniofacial abnormalities. There's all kinds of reconstructive things that you can choose. And if you get into plastic surgery, you can subspecialize within plastic surgery to one of these tracks. The cosmetic route, we all kind of do everything. facelifts, breast surgery, body surgery, but we find our niche. I just a year ago decided that I'm no longer doing facial plastic surgery because I don't enjoy it. I like breast and body surgery. I have a busy enough practice now that that's all I want to do. And it sort of it ties into this health and wellness center concept that I'm bringing into my practice that I'll discuss. So these are all of the things that we do. So you guys ready for a case study?
Let's do it.
All right. So the first probably 8 years of my practice was very heavily weighted in Mohs reconstruction. And for those of you who don't know what Mohs reconstruction is, there are dermatologists who do extra training to do what they call Mohs surgery. Mohs micrographic surgery is where someone has a skin cancer somewhere on the body, but where it works is in the face. Someone has a skin cancer on their face, and the dermatologist will make a small cut to take the lesion out. They go map it. They look under the microscope, and they look for cells that are cancerous cells. And if they still have a margin from 1 o'clock to 3 o'clock, they'll go re-excise it. So the Mohs surgeons or the dermatologists who do extra training, they resect the cancer. Now, the reason that Dr. Mohs sort of invented it was because in the face where we're trying to preserve tissue for reconstruction, we want to take as little tissue as we can to obtain a negative cancerous margin. So I did reconstruction for my first about 8 years really heavily, and I have so many cases, but I don't do as much now. So I want to take you through a couple of the cases that I got and just sort of take you through the mental thinking of my process of thinking of how to handle these. So this was a woman who had a skin cancer on her nose, and you can clearly see they went ham and they had to take a lot of her nose off. So how do I approach a case like this? Well, you guys are going to learn, just like anything else in medicine, we have to step back from being our specialty and remember it's all about history and physical. So I have to determine, is this woman healthy enough to have a general anesthetic? Does she take blood thinners? Does she have heart problems? Take a good history and physical to understand, is she a good candidate for me to proceed with potentially a big operation? So that's the first thing that we do. Once we assess that they're healthy enough to proceed with reconstruction, now I've got to look at a defect like this and determine, what do I do? So when I look at this woman's nose, I've learned over time, number one, form and function, right? Our first goal as a plastic surgeon when we're reconstructing patients is restore form to what we're fixing and function. So she clearly needs to be able to breathe through her nose, and she needs to be able to protect her nose by having it covered. So if you look very closely at the one that's on the bottom right, you can see this is a full thickness defect. She had part of the cartilage taken off from the tip of her nose, and you're staring right into her airway from the top. So she had skin removed, she had cartilage removed, and she had internal mucosal lining removed. And I need to reconstruct all of those different modalities to restore form and function back to her nose. So there are lots of things you can do, and then you can see she's got one just below her left eye, which I'm totally looking over, which is a huge defect, which I repaired, but we'll talk about that. So what tissue options do I have? I could do a skin graft from somewhere. I could do a cartilage graft from somewhere in the body to fix the cartilage. I could do a flap nearby that I rotate to the nose, or maybe I need a distant flap from somewhere, be that either a rotational flap from somewhere else, or I got to take tissue from one part of the body and do microsurgery under the microscope to plug in arteries and veins to bring tissue to the nose to reconstruct it. So these are the different choices that I have. When we approach these cases, the goal is to make a plan, execute that plan, and have a backup plan. Because when things go wrong, you better have something in your back pocket to fix what didn't go right. So I always have, now that I've done this for so long, when I first got into this, I'd be in the back with my book. So this is how it happens, guys. What am I going to do to fix this one? Let's go to the nose chapter. Like, okay, there's like 6 flaps because, we learn principles in plastic surgery. You learn basic principles of blood supply and tissue and how to handle it. Now you have to move forward and figure out, how do I do these flaps that I never did before? And the basics is get the basics down, know the basic safety principles, and then you can proceed. And so my first year or so, I was like that. Now I don't even open a book. I get the defect. I look at it, I go, yeah, there's like 4 different things I can do for that, and I fix it. But that evolves over time.
How much of that is artistic creativity, where you kind of know, right? If you're working with clay, the properties of clay and what that does, or you're working with the oil paints and the properties of oil paints, right? You're working with a specific location on the body and you go, okay, I know where the major vessels are. I know where the major nerves are. I can go to town just based on that with my own kind of creative license.
Yeah, I don't have an artistic creative bone in my body, meaning drawing. I couldn't draw to save my life. So the latter half, but what I do have is I have the hand skills to do the procedure, and I have a mad eye for what looks right. So while I can't draw to save my life, I just know what looks right. I know what structures to recreate and how to recreate them. But that happens over time. But dude, I couldn't draw to save my life.
I'm glad you mentioned hand skills, because that's always a question I get from students is, I want to go into plastics. I want to go into insert surgical subspecialty field here.
Yeah.
But I don't know if my manual dexterity is good enough. Is that something that can be taught or learned over time? Or if you got it, you got it. If you don't, you don't.
Michael Jordan wasn't born knowing how to dribble a basketball, right?
Nope.
It develops over time. So look, I mean, look, there are certain people that are born with good hands and some people who are not handsy. But for sure, over time, over my first 12 years of practice, I've gotten better and better and better every year because I do it over and over and over. And you turn your wrist so much in residency and operate a lot that it's built. It does happen. So my answer to these people would be, don't fear it. It's gonna grow over time. Just like Michael Jordan learned how to dribble and walk and then dunk and all that. It's the same thing. It happens over time.
Yeah.
All right, so we're going to reconstruct the nasal lining. I need cartilage to fix her nose, and then I need to cover it. So let's go through how I did that. So what this picture is showing you from the top left across and then down to the bottom is that this is a cross section of the nose. And inside the nose, just like inside your mouth, there's a mucosal lining. There are various flaps that we can take from inside the nose to reconstruct the internal aspect of the nose. And what this is showing you from A to B to C is they've cut this flap along 3 different sides and left it attached towards the front because there's blood supply coming in. They folded it outward in order to reline the nose, and then you don't have to replace that mucosa back on top because it'll just grow back over the cartilage again. So what I had to do was something similar to this, was to take the internal nasal lining that already exists to recreate the internal lining of the nose. Something else I could have done was to take a skin graft, which we'll talk about. So once I did that, then I had to figure out, well, I need to get cartilage because I need to rebuild the structure of the nose to make it look like a nasal tip. Well, the ear is a beautiful place to get cartilage. And another great place is the rib cartilage, where the soft cartilage where it attaches to the breastbone. In younger patients, older patients, it gets very calcified. But the ear is a great place to take cartilage because we can essentially take the entire bowl out of the ear called the conchal bowl. We peel up a flap of skin, remove that cartilage, fold the skin back down. The ear looks the same. You can see on the bottom left, that's without the cartilage. Put a little bolster in there so they don't get a hematoma or a bleeding underneath there. And then we take that cartilage and we literally mirror the opposite side to recreate the cartilaginous portion of the tip of the nose. If I don't have both sides, then I have to recreate what I know are normal structures from just being in the business, and you learn that over time. The next thing that I have to do is I got to figure out, where am I going to get tissue, right? So if I'm going to put cartilage on the nose, cartilage is relatively avascular, meaning it doesn't have really good blood supply. I need to put a solid piece of skin and meat on top of that thing that has good blood supply in order to recreate the nose and to get that cartilage to live. So there's a flap called a paramedian forehead flap. Now, I'm not going to get deep into the anatomy of this because it's just too much for you guys. But essentially, and I heard this in episode 1, he talked about the supratrochlear and the supraorbital arteries. There's an artery that runs straight up the forehead from the middle aspect of each eye. We know where it is. We can Doppler it out with a little tone we can hear the blood vessel beating with the Doppler, and we can draw this pattern out, and we can elevate the skin based on that blood vessel and twist it down to the nose and suture that on top of the nose. And what we basically do is, just like we mirrored the cartilage, I mirror the skin structures and I cut the end of the flap so that it fits perfectly on the end of the nose. And I'm going to show you how this is done. And then what you see in the last slide here, that's stage 1. Stage 1, we let them sit for 6 or 8 weeks to let this stuff revascularize. So what we're doing is when we elevate that flap, we're severing the blood supply on 3 sides, and we're allowing the remaining artery to sort of really generate new blood supply in that flap and become more robust over time. So we'll leave it for weeks on end because there's little vessels called choke vessels that when it's low pressure in situ, meaning in the scalp, those vessels are all clamped down. Well, once you sever them and you allow the main artery to flow, it'll bust open those other vessels and you've got better blood supply. So we'll attach that to the nose and allow it time to revascularize so that the cartilage can get blood supply and the nasal lining has good blood supply. And then on the right, we're going to divide it and inset it. Now, this can be a 2 or a 3 stage operation. So that's what I did for her. So I elevated this flap after I
let me interrupt with a really interesting question that I think is appropriate to ask right here. A student is asking, is it possible to take tissue from another part of the body to avoid scarring on the forehead? And so I think potentially, and I'll answer this to see if I got it right. The whole point of taking it from the forehead, as you mentioned, is doing the Doppler, finding that artery, is so that you can leave that vessel intact, the blood flow intact, so the healing occurs.
Correct. And there's 2 reasons. The only way that you can take tissue from somewhere else, which you only do in dire straits, is to do microvascular surgery where we take tissue from one part of the body based on an artery and a vein. We sever that. We bring it to the nose. We've got to find an artery and a vein in the nose to plug in and suture together. Sure, you can avoid a flap on the forehead, but what you don't realize, because I have the knowledge to know this, these scars heal almost flawlessly over time. Yeah. But what's also important here is, remember, we talked about this in the beginning. The goal is to replace form and function. Form, taking like tissue to like tissue, replaces form. The forehead skin gets the same solar damage and exposure that the nose does. It's very similar thickness. So we want to replace like with like. They're not exactly alike, but that's really the main reason.
I don't want my butt cheek hair growing on my nose in the future. That's what you're saying.
Yeah, no, you don't want to be a butthead. So what I did here was I dissected this flap out. You don't see it, but I put the cartilage grafts in there. I did the lining flap, and then I flapped this down on top. Also, if you notice, I fixed her cheek. So what I did to fix her cheek was I did an adjacent tissue transfer, which is she had a hole right here. I made an incision underneath her eyelid extending all the way back towards the ear. I made another incision down the side of her nose. I elevated her entire cheek skin, advanced it forward, laid it back down, and sutured it in place. That's called an adjacent tissue transfer, meaning I moved skin from regionally into that area based on blood supply coming in from here to keep the flap alive. And now what will happen over time is that flap will grow new blood supply from the face into that tissue, and it'll live and look beautiful later, and you're going to get to see that. So stage 2, I divide and inset the flap. So you can see that what looks like a gnarly scar on her forehead, you're going to see healed up pretty well. Now, something else to keep in mind, guys, when I do these procedures, I'm well aware that some of these scars may not be great, but guess what? I'm a plastic surgeon and I know what I'm doing, and I can go back later and revise those scars. So if something doesn't heal great initially, we always have a chance to go back and maybe cut out a portion of the scar that didn't heal that well and make it look thinner and less noticeable. So in this case, what I've done is I've divided the flap and I've returned where the supratrochlear vessel was. I've returned that skin, and now that skin that's on the tip of the nose has had 6 or 8 weeks to grow its own blood supply from her nose into it, and it can live on its own now. So you can see from the side view, she's got great tip projection. That skin has really covered her nose well. We've replaced her form, we've replaced her function, and this is what she looked like. I don't remember. This was months out. But really, is this perfect? No, I'm never happy with anything I do. I always think I can do better. That's just my chairman used to say in training. He used to say, "I'm only happy with 10% of what I do," and I was like, "What is wrong with this guy? Does he think he stinks or something?" And now that I'm in practice, I'm like, "Yep, know exactly what he was saying." And what he was saying is he's such a perfectionist that I always see things that I think that I can improve, but the patient may not see that, you know. But I was happy with this result. This turned out really nice.
That's amazing. Talk about, we've been getting a lot of questions about kind of the advancement of stem cells and 3D printing of cells and matrices that can be used in surgery. Where do you think that's coming?
You know, we'll see. I think it's going to be probably best for burn treatment when we need skin. When you got someone with like 80% burns and you've got nowhere else to take a skin graft from, being able to grow skin that's compatible with them and they won't reject is huge. It's going to be interesting to see where we go. Like, are we going to be able to grow a nose one day? I'm sure long after I'm gone, if the world hasn't ended by then, that we're going to see that in the future. I don't know a ton about all of that. I do know about like PRP or platelet-rich plasma, where we draw blood, we spin it down, and we take the serum that's got growth factors, and we can inject that into areas to help, regenerate blood supply and things like that. They do it in joints. We do it in the face. And it works okay. I mean, I think there are some places where it works. It's not perfect yet, and it's definitely not mainstay of therapy right now. But, it's going to be interesting. Science is amazing, and we're going to be always evolving.
Yeah. Very cool.
All right. Let's see. One more. I got a couple more cases. And you guys let me know if you want me to stop and you just want to ask questions. We can do a little Q&A as well. All right. So this woman came to me, right? So, again, I'm going to approach this the same way. I need to restore form and function. You can see her lips a little bit droopy, even though her head's turned to the side, because once all of that cancer was cut out, the tissues relax away, and we need to kind of pull that lip back up and get it fixed. Now, I start to think to myself, where am I going to get a piece of skin to fix this? What are my options to reconstruct something like this? Well, some of the options are something called an island pedicle flap. What that means is you can see here that the defect and the tissue next to it, like I did before, you can make incisions on 3 sides or 2 sides, and we can leave the pedicle. You see, it's called the pedicle. There's blood supply coming into that tissue. We can make it mobile enough so that it lifts up. We slide it into the defect, and we drop it back down. And where we took it from, there's usually enough laxity to close that primarily. That's one option. Another option is a full thickness skin graft or a split thickness skin graft. Let me tell you what the difference between those two are. This is a cross-section of your skin, the epidermis, the dermis, and the hypodermis into the subcutaneous fatty tissues, the yellow stuff. A split-thickness skin graft just shaves off a little piece of the top of your skin. Those grafts tend to contract and tighten over time, so that wouldn't be great on the face because it would tighten and pull on other structures. A full-thickness skin graft encompasses all the full layers of the dermis, and when you include the full layers of the dermis, while that graft will contract some, it will mostly not contract and cover the area. So a full thickness skin graft could be an option here for her, because remember, back to your history and your physical, you can clearly see she's not a young bird. She's older. She has microvascular disease. She may have some heart disease. She may have things that prevent me from doing one option versus the other. And those are the things that are going through my brain when I'm deciding on what I'm going to do. What I did for her was a combination of both. So if you see the incision, I didn't get a great picture of this because this is so old, but her neck, you see the little part that goes into her neck. I essentially lifted all of the skin of her neck and advanced it up into the defect and part of her lip and laid it down and closed that primarily. And what I couldn't finish off, I put a full thickness skin graft on it and called it a day. And this is what she looked like, I think about 4 months out. This was her. So she's a little scabby along the nasolabial fold, but what we've done is we've restored form and we've restored function. So great case. These cases are really fun.
That's amazing. A couple of questions have come up about consent of patients for pictures. Obviously, you're a physician. I'm a physician. We understand HIPAA, and we're not violating HIPAA. Talk about what it's like for surgeons. Obviously, there's what students don't know. When you go for your oral boards and your board certification, you're submitting pictures and cases and all of this information. Are a lot of these pictures from that time, or are you constantly getting consent from patients now as well?
Yeah. So, I mean, for those of you who don't follow me on Instagram and TikTok, you probably should. I still get consent. We have a lawyer that's drawn up a form for us that goes through the different scenarios. So can we use it for just in-office use, for social media, for the website? They can pick and choose or select all. So I don't ever show anything on my social media that the patient hasn't given me permission for. And I get as detailed to, do you want me to cover your tattoos or do you not care? Can I show your eyes or do you not care? And a lot of them, they want to help other people because they did their research to get reconstructed, and they think like, hey, I got to see other people who let the doctor let them use my pictures. So I want to give you permission so that I can help other people. And there's some people who are like, look, no, I'm not down, but I don't use them unless I get permission.
Yep.
Which is hugely important. It's funny. I get that on TikTok all the time. They're like, imagine you're the doctor making a TikTok during surgery and the patient is asleep on the table. And I'm like,
yeah. Well, it's like dentists. Was it a Canadian dentist or no? I don't think it was Canadian. The dentist who was like doing procedures on a hoverboard, and then it turns out he had tons of medical fraud as well, and now he's in jail.
Oh God, yeah, not good, not good. But anyway, so I wanted to talk real quick about some of what I do. I do a lot of breast cancer reconstruction still. This is a story that's kind of near and dear to my heart because this is a nurse who I took care of. I think my first year in practice, she was an ER nurse in a distant city in Arizona. And she had breast cancer and was going to have a double mastectomy. And so there are many ways to reconstruct the breast. We've sort of gone through some of them with distant tissue transfer. Those are called free flaps or microvascular surgery, where we can take tissue from the tummy and plug it into arteries and veins in the breast to reconstruct the breast. There's too much to talk about here to talk about who's a candidate and who's not for that. That's one way. So we can reconstruct the breast with your own tissue if you have good ample tissue. Another way to reconstruct the breast is implant-based reconstruction, which is mostly what I do. I do some flaps from regionally, like the one I did from the forehead, where we can take the latissimus flap from the back and bring it to the breast. I didn't have a chance to put that together, but this was a patient of mine who had a double mastectomy. So I want to give you guys a little taste of what it's like to reconstruct the breast. So this is called a tissue expander. There's 2-stage and 1-stage reconstructions, and this has evolved greatly over just my past 11 or 12 years in practice, where everyone I reconstructed in the beginning got a tissue expander, which stretches the skin. So the breast surgeon comes in, they perform a mastectomy. We then place this device either under the muscle or over the muscle, put it in the right place, close everything up, and then over the ensuing weeks, the patient comes into the office, and here's what we do. We inject fluid. This is just the other day in the OR. I put methylene blue in mine, which I'll explain another time, but we inject fluid into the tissue expander, and we can do this in the clinic slowly over time until we reach a point where things are big enough to go back to the operating room in a second operation, take out the tissue expander, and then put in a breast implant. So for this patient, that's exactly what I did. The other way that you can do this is you can go direct to implant. And going direct to implant is something that we really do a lot today. There's something called a nipple-sparing mastectomy, where they spare the nipple. They don't have to get rid of the nipple, because for a lot of breast cancers, they have to take the nipple off. But now we're able to spare the nipple, which is really great for reconstruction. And the surgeons have gotten so savvy at doing these mastectomies that many, many times I can just put the real implant in right away and skip this whole step that I'm talking about. And I just did one this morning. So that's evolved over time, and breast cancer reconstruction has changed so much over time. But this is a tissue expander. And so this is the result that I got for this young lady. So these are just implants. I expanded her. We went back and took out those expanders, and then we placed silicone implants. And then the next step for her, if she desired, would be nipple reconstruction. And you could either have tattoos, or there are little flaps that we can do to create a nipple and then tattoo the areola. Unfortunately, and I get emotional about this, this was a patient of mine in her 30s, and she passed away. So she didn't make it, but she became we were very good friends because she was a nurse, and we had a long journey together. And my wife and I were driving through Kingman, Arizona, and we got to see her before she passed away. But this is the real life stuff that you have to deal with, guys. I mean, I get close with my patients. It is what it is. I don't hold back making a relationship with my patients because I'm scared about what might happen in the end. I'm grateful to have had her as a patient, and I learned so much from her about her strength and what she went through. And while it's sad, it's a growing moment for me. And you guys are going to go through this as you go through medicine.
Let's just because I know it takes a few seconds. If you want to come on, let's have a couple people come on. We'll do a little bit of Q&A. All right, so we got James won the race to get here first. James, are you there?
Hello, does it work?
Oh, sounds like I was gonna cuss a rock star over here.
It got you, dude. Sean Connery voice.
You got me. I'm like, oh, who that? James is a voice stud. What's going on, James? What question do you have?
Hello. I guess this is more towards private practice. I've talked to a couple of physicians, and I've kind of worked with a couple of physicians that run their own practice. And while I guess it's kind of the dark side of medicine, a lot of it is finances and insurances because they're running a business rather than just like a clinic. It's not just a clinic, right? It's also a business for you.
Absolutely.
And no, like since you're in plastic surgery, a lot of the procedures that you do must be considered elective by a lot of insurances, which means that they don't really want to pay for those procedures.
Mhm.
So how do you kind of balance finances with working with patients? Because I know like it's very easy if you kind of just go like it's not good to be bad with your money, right? When you're running a private practice, because you have to look at it long term.
Of course.
Does that ever get in the way of kind of how you recommend treatments to your patients? And if in the case that insurances don't cover these treatments, how do you have these conversations with the patients? And do you ever kind of provide procedures for free if patients really can't afford it and you think that kind of this test is necessary for a procedure that you want to do on this patient?
Great question. I have a quick and dirty answer because it's in the news every day. Obviously, with COVID-19, it has immensely helped your practice, right? Because you just diagnose everyone with COVID and make lots of money.
Exactly.
It's what you do.
Exactly.
Anyway.
Yeah.
Sorry.
So look, man, here's the deal. What I do for a living, not all plastic surgeons do reconstructive work. Some people did it in the beginning and then they became purely cosmetic. My practice has evolved over time and I was mostly reconstructive in the beginning. We take insured patients. I try, you hit a great point. And I think what a lot of people don't realize is the reason that I went into private practice was because I wanted to call my own shots. I want to build something. I didn't want to be told by a hospital what I could and couldn't do. But being that said, I'm running a business, right? So I cannot do free surgery for everybody. And sometimes we have to turn people away because we're losing money by taking care of them. And you're delving into a very difficult area of medicine where it's like, does everyone have the right to be treated? Yeah, I think they do, but that doesn't mean that I have to treat everybody that comes through the door. Now, I do pro bono work. I just did one for a kid who was being bullied because he had gynecomastia or male enlargement of the breast. His mom's a teacher. They didn't have a lot of money. I put this on TikTok. They couldn't afford it. Time went by. I really felt bad. This kid was like singing to me because he was 17 and the football team was bullying him. I called them back. We reduced the price. They still couldn't do it. So I called the surgery center and I said, I'm going to do this for free. They said, we'll give the facility and the anesthesia charges for free. And we did it for free. That's one scenario. So I do some of that stuff. But then I've got the cosmetic and the reconstructive side of my practice. Cosmetic is cosmetic. You want a breast augmentation? This is what we charge. That it is what it is. It's called elective surgery. The reconstructive stuff, sure, we bill insurance and we probably don't get paid half the time. I always tell my office manager, please don't tell me how much we don't make doing reconstructive because I enjoy doing it and I don't want to stop doing it. And if you tell me how much we don't make, I'm going to probably stop doing it. But my cosmetic practice fuels my desire to continue to do the reconstructive stuff despite not making money. And look, man, it's not all about the money. It's not. If you're going into medicine for the money, you're going to be seriously underfulfilled in your life.
Yeah, 1,000%. Great job. All right.
Thank you for the answer.
You're welcome. Good question.
I don't see anyone's name, so next person just jump up.
We got two.
I think there's more than that.
How about the female?
Hi.
Yeah, you can go ahead.
I'm
Rachel. There you go.
So
I
nice
see
to
Rachel.
meet you.
All right.
I wanted to ask, what is your favorite procedure to perform?
Man, everyone loves to ask this. It's kind of funny that I told you that I don't do facial cosmetics anymore. Rhinoplasty was my favorite operation, but you have to really do a lot of those to master them. And I wasn't doing a lot of them here. So that was my favorite. But I will tell you, between breast and body, I would have to say that I enjoy breast surgery because I do like to do the reconstructive stuff. But I also like taking quote unquote patients that were botched cosmetically and fixing those because they're challenging. I also like bread and butter, straightforward breast surgery too. So breast, I enjoy breast, but I like body too. But I do really enjoy breast surgery in general.
Cool.
Awesome.
Thanks, Rachel.
Thank you for answering my
You're welcome.
Frank, let's go with you. Oh, I can't hear you.
Yeah, I can't hear him either.
Oh, let's go with.
Okay, can you hear me now?
Oh, now I
Yeah.
can hear you.
Okay, thank you for having me on. So my question is kind of simple. How do you keep yourself motivated and driven to do what you do on a daily basis? Like what inspires you and what keeps you passionate?
Yeah, that's a great question. Everyone loves to ask that. And I think that it's an easy answer for me, Frank. I love what I do. I get unbelievable joy from watching the happiness that I bring to other people's lives doing the creative work that I do. So for me, it's pretty simple. I love what I do, and that motivates me to continue doing what I do. If you're not happy doing what you do, it's hard to stay motivated doing it. But I have a passion for what I do, and I chose this profession for a reason. And that reason was I want to drastically impact people's lives. And I feel like I do that on a daily basis. So as long as I'm moving the needle forward towards that, it's easy to stay motivated. And I have so many other things that I want to do, and that keeps me motivated too, working towards that.
Awesome.
Great. Thank you.
Question.
All right, let's go. Haya? Is that how you pronounce that?
Yes, that's actually exactly right. I'm so surprised that you were able to say
It's my Jewish roots. I'm assuming.
Awesome. Yes. Well, I'm Jewish too. So there we go.
Me too.
So Dr. Brown, I was just going to ask you, how did you raise a family and how did you balance work life with normal life? And what kind of support did you get from, for example, babysitters and extraneous sources rather than just your wife or your parents, for example? I don't know.
You know, my wife is watching this, so we either need to patch her in or you're going to get the abbreviated answer. No, that's a great question. So look, here's how it works. I also have to support her in her journey and what she wants to do in life. And I think by us having that mutual respect for each other, that's how we make it work. I mean, we're a team, and yeah, there are a lot of hours and I work a lot of hours, but part of why I chose my profession too is that I'm able in private practice. I'm able to control my hours. I work as hard or as little as I want. And so I think that it's a great question that you asked, but you and your partner have to have an understanding from the get-go about what you're trying to do, where you're headed. Yeah, I think if you both have a vision of what that path is, you make it work, and it just happens. And my wife, when our twins were born, she was a dental hygienist practicing and kind of stopped practicing to help take care of them because that's what she wanted to do. And she's done that for many years, and they're almost 11 now. And she's also started some side businesses on her own that she's doing at home. And so that fulfills her. And so I think that, again, my answer to that is when you find your partner, you either have a clear understanding that you're on the same page or it'll never work. And if you are on the same page, it just happens.
Yeah.
Good question.
Awesome. Thank you so much.
You're welcome.
All right. Let's go with Sky. Are you there, Sky? Unmute. Maybe. Ariana.
See everybody?
Ariana.
Oh, there. Sky.
Sky got scared.
Sky ran out.
Oh, hi. This is Ariana.
Hi, Ariana.
Yeah, I just wanted to, I have two questions, but I can just start with one. The first one was in regards to one of your procedures. It was the, nose to reconstruction, I believe. And I remember you stating that, correct me with the terminology if you need to, but I remember you saying that, a split layer skin graft, lacks the flexibility, that a full skin graft would have. So I would just like to know if there were any cases in which a split layer graft would actually be preferred.
Oh, yeah. So split thickness or full thickness is what you're talking about. A split thickness skin graft, again, is like when you fall on the street and you road rash, take off a layer of skin off the top. That is a split thickness skin graft. We use those grafts in many places. We use that in burn surgery. Sometimes I'll use that in trauma cases on the arm. Actually, I posted one of these on TikTok where a guy had denuded his arm, and we put a wound vac on there to allow good, healthy, bloody tissue that has good rich blood supply, and then we put a split thickness skin graft on top of that. The benefit of a split thickness graft is it covers a broader area, and the skin regenerates from the dermis. You grow new epidermis, and then you can regraft from the same area, and that's precisely what we do in burn patients. The full thickness graft, like I said, when we take a full thickness graft, we're going to put that in an area where we don't want contraction to happen, and that's usually in the head and neck area. And in that case, you have to be able to fully close that wound or it will not heal itself. So when we take a full thickness skin graft, I have to make sure that I pinch the two edges together so that I can close the area where I take it from. So that's the difference between the two. Good question.
Thank you.
What was your second question?
Oh, My second question. Okay, so I would just like to know if either one of you have any ideas on how to get involved, especially during the pandemic, because I feel that this is one avenue, of course, which I appreciate. But I had a lot of plans for, volunteering for hospitals and so on, but all of that stuff was slowed down, if not canceled. So I'd just like to know if there are any remote opportunities out there.
You can go and then I'll go.
Yeah, I was going to let you start and see what you've done.
So here's what I'll tell you. What I would tell you is this. We'll see if Dr. Gray agrees with me. You're in the same boat as everybody. Everyone's in the same boat. And while we always tell you guys that getting shadowing experience will help build your resume, you're not building your resume just like everyone else is not building theirs, and you're on the same playing field as them. Now, what does that mean to you at the end of the day with your training? It means nothing. You're going to get all the training that you need in residency. But yeah, sure, if you're trying to explore what you're trying to do, it would be helpful. But just remember, you guys are on the same playing field. It's not like you're not getting to do it and then the other person's getting to do it. Most everyone is still shut down from COVID. They won't let me bring anybody into the operating room. And so that's what I would tell you, is that you're on the same playing field. What would you say?
Yeah,
Dr.
kind of the
B?
same thing is everyone is in the same boat right now, because hospitals and clinics and everything else are the ones setting the rules that nobody can come in, right? There's a risk to patients of COVID exposure, SARS-CoV-2 exposure. And so it's not going to happen. And so obviously virtual stuff like this, look, and obviously this isn't true shadowing, but it's better than nothing in my mind. So I'm glad that there's 1,700 of you here hanging out, learning from Dr. Brown right now. But there are other opportunities. There's crisis hotlines, which have been overrun by volunteers. They still need volunteers, especially overnight volunteers. But everyone is also looking for potential virtual opportunities, like virtual hospice and virtual like retirement home visiting. The people who are in nursing homes who have had visitors come and play music and sing, and just visitors to come sit with them, they don't have all of those people as well because they can't go in. And so virtual opportunities like that are good. Yeah. Virtual scribing is a thing. Again, it's not real scribing, but it's still scribing and you're still learning. So virtual scribing potentially. So just it's not going to be perfect. Obviously, medical schools are going through the same thing, right? Medical schools are trying to figure out where to put students, and medical schools are virtual right now, so they're going to understand when you apply to medical school.
Mm-hmm. Yep.
All right, Dr. Brown, I want to respect your time. Thank you so much for at the last minute coming on, saving the day,
I appreciate it.
Georgia Bulldogs do. I appreciate you, man. Thank you so much again for your time, your wisdom, and sharing everything tonight.
My pleasure. I want to let everybody know that I'm assuming you'll put my social media stuff up, but you guys can feel free to DM me on Instagram. Feel free on TikTok. I don't have the DMs turned on, but you can message me to Instagram, and I answer almost everyone. So if you ever have questions, I'm an open book. If I don't get back to you, it's because I'm busy operating and running my practice, but I will eventually get to you.
Busy doing your thing. Dr. B, Dr. G, we're out. Thank you everyone for hanging out with us. Have a great night.